Thanks everyone for coming today. I'm sure a few more people will start logging in as we get going here, but I wanted to start on time today. We're so glad to have Gaurav Chattree joining us today. Not only is he a great speaker, but he's helping out at the very last minute since our regularly scheduled speaker had to cancel due to jury duty. So, and we will reschedule her sometime in the spring. So, Dr. Chattree was a recent movement disorder fellow at Stanford, and he's continuing on with that. And he's also been hired by Stanford to see patients either a day or two a week and continue on as a research fellow at Stanford as well. And he talks to us every year about what's happening in Parkinson's disease treatment. And he's really great about keeping his pulse on what's going on in the research community and in the drug pipeline. So I'll let Dr. Chattree take it away. And if anybody has any questions, I'll monitor them and just put them in the chat or the Q&A box. And Dr. Chattree is unusual in the sense that he likes to keep the number of slides to a minimum. So you'll see maybe 20 or 30 minutes of slides at the most here, but give a lot of time for question and answer. So
yeah, thanks, Robin. And thanks everyone for being here. And like Robin's saying, put questions in the chat. Robin, we can, I'll pause the talk and we can answer questions as they come. So we can make this interactive. So yeah, as Robin was saying, I'm a movement disorders research fellow. So I see patients, and then I also work in the Schnitzer lab trying to find new drug targets for Parkinson's disease. So yeah, I'm going to give an update for 2023 in terms of what's going on in Parkinson's disease treatment. Some of this is going to be a repeat from the talk that I gave last year. And I'll try to update you a little bit on some of the things we talked about last year. So let me just give a disclaimer. I'm not involved in any of the trials today. The goal of this talk really is to just educate you on the major trials going on in Parkinson's disease today. And I focused on trials and topics that you're likely to hear about in the news. So a little bit of background. There's two categories of treatments in Parkinson's disease. So there's a disease modifying therapy category. So these are therapies that slow or halt the progression of Parkinson's disease, meaning they prevent further neurons from being impacted by the disease. Right now, unfortunately, there's no approved therapies like this. The only thing that seems to be disease modifying is exercise, and that's been shown in a trial that was done in 2017, 2018. Patients that regularly exercised, in that case, the paper they did stationary bike, they had some slowing of disease progression. But the goal is to develop some medications that can do that as well. And so they could be combined with exercise or also provide a similar or stronger benefit. The other group, the other category are symptomatic therapies. So these are medications like Sinemet, like Rytary, like Azilect. So they don't slow down the progression of Parkinson's disease, but they help alleviate symptoms. They improve or restore function. So they can improve motor function, cognitive function. So I'm going to start by talking about what's going on in the disease modifying therapy world. Okay, we have a chat. Let's see. Oh yeah, please enter questions here. Great. All right. So in the disease modifying approaches section, there's hundreds of approaches at some stage in development, but I'm going to focus on 4 that are entering phase 3 or have already entered phase 3 in 2023. Okay. So the first one, and those who saw me speak last year, this is a little bit of a repeat, but I'll give a small update on what we know since then. So this category of drugs is the GLP-1R agonists. So they were initially interestingly isolated from the venom of the Gila monster in 1992. And Dr. Zhong En noticed that when the Gila monster would either, I think it was a bit of human, and probably they tested it with some animals, they found that its glucose was going low, the whoever was bit by the Gila monster. And so he worked out why the glucose was going low with this venom and found this compound that was stimulating the pancreas to release more insulin, which then in turn brought down glucose. So it was then created as a medication for diabetes, and it's approved for diabetes, and it's been approved for over 10 years. And recently, this is all in the news, it is also been approved as an obesity drug. So Ozempic, Wegovy, I think is the other similar type drug. And so these, have now been shown to be effective for obesity as well. And so anytime a drug gets approved by the FDA, regardless of what it's for, there are groups out there that explore, could this possibly have some benefit in Parkinson's disease? Could this possibly have some benefit in Alzheimer's? So they do some testing in the lab. And the rationale for this is that drugs often have, multiple effects. This drug has already been approved by the FDA, so that means it's known to be safe. So it'd be a huge bonus if it also was shown to be helpful in Parkinson's. So studies were done in Parkinson's mice, and it showed that potentially this drug was helpful. So it was moved to humans, initially with a small phase 1 trial and then phase 2 trial in 2017. So in this trial, there were 32 patients who received the treatment, exenatide, and 30 patients who received placebo. They were on the medication for around 48 weeks, and then there was a 12-week or 3-month washout period where both the exenatide and placebo were stopped to see what would happen. So you can see the chart on the right. The y-axis is the UPDRS part 3. And so higher is worse. A higher number is worse. And what this is, when you come to the clinic, we always have you doing these finger taps, hand open, close. You're probably wondering, why the heck are you making me do these movements? That's because we're calculating this UPDRS score. Every time we see you, we try to do those movements. We try to calculate that score to track how things are going. So now coming back to the chart. So those who took exenatide, within 12 weeks, there seemed to be an improvement in their UPDRS, aka their motor ability seemed to improve. It sustained over the next, 36 weeks. And then when they did the 12-week washout period, those patients still had some, benefit. And especially when you compare to the placebo, who gradually, had an increase over time, which is normal and expected in Parkinson's, that there's going to be a gradual change over time. So this was pretty exciting that exenatide seemed to prevent that gradual progression over time and also provided some benefit. And the adverse effects were minimal. They weren't worse than placebo. So, everything was looking pretty good here in phase 2. There's another piece of data that was good. So you may have heard of the DAT scan. So that is a scan that we do on the brain that is essentially is a marker for dopamine levels. And so they showed that patients who were on exenatide had less of a change in their DAT scan, meaning their dopamine levels stayed more stable, which is also a good sign. So seeing the results of that, there was, many different groups who were like, well, let's try to, do more trials. Let's try, to be honest, different pharmacological companies were like, well, let me try my version of the drug. So then there's multiple trials that were started, within a couple of years afterwards, as you can see here. In 2019, this is the big one, is phase 3 that was started in the UK. So this is 200 patients. Each patient was followed for over 24 months. That's the plan. And then they're going to look at the UPDRS score, the movement ability, and the quality of life. Then there were many other smaller trials that were done. Also phase 2 trials, different versions of the drug, all over the world, basically. And unfortunately, so these trials, as you see, the ones from Sweden and France, they have been completed, but there's no result yet. That nothing has been shared yet. But the Cedars-Sinai one, there has been a preliminary statement that's been released. We don't have the raw data, so I can't give you definitive details about this trial, but a statement has been released. And so this is their statement. The primary analysis showed there were 37 patients on this liraglutide, which is the GLP-1R drug in this case, and 18 on placebo. At the 12-month period, those who took liraglutide had overall improvement in their quality of life. However, they couldn't show that there was a clear difference between the UPDRS motor score or movement ability between those who took liraglutide and those who took placebo. But they make one more other comment, which is important to note, is that those who are on placebo, for whatever reason, they also had an improvement. So that's what made it challenging. And so I think what we can take from this statement is not necessarily that the drug doesn't work. It may have been that this 12-month period was short, or there was something about the trial where the placebo arm also had some benefit. So it just made it hard for them to, because the placebo arm benefited as well, it made it hard to say whether there was a true benefit. I don't think this means, we should give up on this drug. I think it means that just more studies need to be done. And I think the big one will be this exenatide trial. So do you know any drug interactions with Aricept and escitalopram? No, there's no interactions with those drugs. Yeah, but I just want to say, please don't go out and take this drug. That would be my recommendation. Let's maybe wait to get some data. I think hopefully we're going to hear from these other smaller trials this year because they've been completed. We're just waiting. Yeah, so these are all the same mechanism of action. They're just different companies, so different pharmaceutical companies. Yeah. Okay, so now I'm going to move on to another drug that's entering phase 3 this year. This is Ambroxol. So a little bit of a background and disclaimer about Ambroxol. So Ambroxol, in some parts of the world, many countries, it is approved for the last 40 years to be used in cough syrup to help break up phlegm. It is not approved in the United States. That's not because it's been shown to have some negative effect. There were a couple, reports of that, but for the most part, it's actually patent reasons. Like drug companies felt that they couldn't make money off of this drug in the United States. That's a common thing where, a drug will be approved somewhere else, but then it doesn't move over to the US just for financial reasons. And so I just want to make one disclaimer though. So in the PD trial that I'm going to talk about, a very high dose of Ambroxol was used. That level, I don't think safety has been fully established yet. Please don't take Ambroxol on your own. Okay, now coming back to the PD relevant trial. So glucocerebrosidase is a protein in the brain that helps brain cells clean up waste products that they no longer need. So as brain cells are performing their day-to-day function, there's some waste product that builds up. Glucocerebrosidase helps clear that. Mutations in glucocerebrosidase are associated with increased risk of Parkinson's disease, suggesting that glucocerebrosidase is important, plays an important role in the development of Parkinson's disease. In animal studies and other laboratory studies, it was shown that Ambroxol seems to act on glucocerebrosidase and make it work better. It somehow allows it to clean up waste better, which may protect the brain cells. So then it was moved to humans, and they did a very small trial in 2020. It's 17 patients, okay? And what they showed here was that none of the patients, I think they did it for 6 months, that none of the patients had any significant side effects, which is good. And then they showed some data suggesting that it was in fact making glucose cerebrositis perform better. So that's what they showed. They didn't show any improvement in symptoms for the patient per se, but they showed that they seem to be achieving their target, which is acting on glucose cerebrosides. So then, with that data, it was felt it was sufficient to move to phase 3. This is also happening in the UK. 330 patients total, 2-year study. Some will take Ambroxol, some will take placebo, and the similar markers will be looked at the 2-year marks of quality of life and UPDRS, or movement ability. Okay. All right. Drug number 3, Buntanatap. Okay. I would say how this drug works is unknown. Okay, this is what the company claims, that it seems to reduce brain cell production of alpha-synuclein. I think still work needs to be done to really confirm that, but that is how they're saying this works. Alpha-synuclein, just a little bit of background of that, is a protein that's been shown up to build up in the brain of most patients with Parkinson's disease, and misfolded alpha-synuclein clumps up and is thought to be toxic to brain cells. Okay, so then this is a phase 2 trial that was done in 54 patients. It was done just last year. And there's 2 charts on the right here. So the top chart is patients took Buntanatap for 25 days. And the top chart shows that those who took 10 milligrams had some potential improvement in their motor ability. The bottom chart shows overall quality of life might have been better with the 10 to 20 milligram doses at 25-day mark. I'll say we have to be cautious here. This 25-day mark, it's just surprising, like that a drug could somehow produce this effect within 25 days. It's possible, but we want to be cautious. So we'll be following along, of course. And so what's next? This one is also moving to phase 3. UCSF is recruiting patients. So if you are interested in this medication, you can go to UCSF's website and you can look into potentially participating in this. Basically, patients will take 10 milligrams, 20 milligrams, or a placebo for 6 months, and then be evaluated on movement ability and quality of life. Okay, the last group of medications I'm going to talk about. Okay, let's see the chat. Yes, normal brains have alpha-synuclein. Alpha-synuclein is a normal protein, you're right. In Parkinson's, it seems that there's basically there's misfolding of it, and then it starts clumping up, and then that clumping becomes toxic. So it's a good question. This drug seems to reduce alpha-synuclein. Why doesn't it, wouldn't it hurt normal patients or hurt the normal production of alpha-synuclein? I think their claim is that, the brain is probably trying to, so brains typically have a feedback mechanism. So in the sense that, let's say the brain is trying to detect how much normal alpha-synuclein do I have. It's gonna see a low level because the alpha-synuclein is getting misfolded and clumping up. So it may ramp up its alpha-synuclein production. And so this is designed to basically tampen that rampening up process. That's the overall hypothesis. Yeah. Okay. So then the next class of medications are LRRK2 inhibitors. So a little bit of background on what's the hypothesis here. So there is a gene called LRRK2. It's been shown that mutations in this gene seem to contribute to the development of Parkinson's disease. That's statement number 1. Okay. Then it's been shown that these mutations seem to make the protein or enzyme that is encoded by LRRK2 too active. It becomes hyperactive. Okay, that was shown in laboratory studies. So then the hypothesis is that this overactivity of LRRK2 somehow leads to Parkinson's disease, but exactly how is unclear. From that comes the goal, okay, let's design a way to slow down the LRRK2 enzyme. It's too active in Parkinson's. Let's try to slow it down. All right, so there's many different strategies. There's, normal medications that you would take by mouth, and then there's genetic modifications that are being worked on to try and act on the LRRK2 gene itself. So here's where we are. So Biogen and Denali have actually started 2 trials simultaneously with their medication, which is like a small molecule, something you would take by mouth. And they went to a phase 3 trial in patients that have the specific LRRK2 mutations that are known to be associated with Parkinson's disease. Okay, so I think they feel more confident there, in patients that have this mutation. So they actually went straight from phase 1 to phase 3. They jumped phase 2 for this. And so this is going to be a big trial, and results are expected in 2031. So it's a long trial. And then simultaneously, they're doing a phase 2 trial in all PD patients, whether you have a LRRK2 mutation or not. And so that will be phase 2, so a little bit shorter, and results will be expected in 2025. Yeah, if anyone's interested, if they have the LRRK2 mutation, you can talk to your physician about it. And actually 23andMe can also give you that information if you're interested. Okay, so let's pause there. I talked about multiple drugs. Any questions about that? So we do have 4 drugs that will be in phase 3 this year. So, that in a way that, I would say that's good news, because we're phase 3 is the last stage. There seems to be positive signals for these medications. So, I think we should be hopeful. All right. Yes, please wait before the data comes out before taking any of these medications, because many times what happens, and I think this is just something about human medicine and humans in general, we're just so complicated. Phase 2 will look perfect. And then in phase 3, that's where all the problems start showing up. Sometimes it's because, now you've got a wider population group. So there's many different type of people that are being exposed to the medication, and you're seeing side effects that you didn't see before. And sometimes there is just like statistical issues that can happen in phase 2, that once you do it in phase 3, you don't see your positive result anymore. So while we should be hopeful, I just want to emphasize again, please don't take these medications until we get more data. Okay, so now I'm going to move on to symptomatic therapy. So again, these are medications like Sinemet, Rytary, Azilect that help with motor ability. So there's been new formulations of old drugs. So opicapone, sulfonamide. The big one here that I'm going to just mention, actually just briefly, is subcutaneous levodopa. So that would be a levodopa patch that you can wear on your skin. And I think you wear it 24/7, you change it every day. And that showed positive effects in I think it was a phase 3 trial, phase 2 or phase 3 trial. So that will be moving to the FDA for approval. So I think that for some patients who have dyskinesias or have other issues with levodopa sometimes getting too high in their system, this subcutaneous levodopa, I think will help with that. So I'm looking forward to this subcutaneous levodopa being approved. I think it's very likely it'll be approved. I don't know how long it will take, but maybe 1 or 2 years. Yeah, sub-Q patch in this case. Yeah, it'll be a patch. Just another comment. So these medications, the new formulations of old drugs, they'll be useful in special cases, but for the most part, they don't necessarily change treatment for most patients. There are two interventional approaches, meaning there's some procedure being done on your brain. I did talk about this last year, and we don't have major updates on these approaches, but I'll just discuss them again for those that weren't at my lecture last year. So number one is focus ultrasound. So the general idea here is that there appears to be this area in the brain called the subthalamic nucleus that in Parkinson's disease is sending out bad signals to the rest of the brain. It was shown in 1960, 1970s, humans and monkeys, that if you got rid of this area, you could get improvement in your movement ability, potentially by reducing this area's ability to send bad signals to the rest of the brain. And you don't necessarily need this part of your brain, I think, as an adult. I think you need it as a child, but maybe as an adult, you may not need it. So they were able to get rid of it. But the way they were getting rid of it back then was like burning it, and there were just too many side effects. And it would damage areas that they didn't want it to damage. So it was stopped. And so then from that, though, actually DBS was created, deep brain stimulation was created. And a major target for deep brain stimulation is the subthalamic nucleus as well. And one of the ideas of how deep brain stimulation works is it's almost like it goes in there and turns the subthalamic nucleus off. Okay. But you then, with DBS, you have the electrodes, you have the wires, you have the battery, which, it's not so bad, but potentially, some groups are thinking, well, can we go back to just lesioning it in a better way, getting rid of that area in a better way? So that's where this subthalamic nucleus focus ultrasound comes in. The idea is that you wear this big cap over your head. You come into the clinic, you wear this cap over your head, and then it fires high energy ultrasonic waves directly to the subthalamic nucleus, and hits it with high enough energy that that tissue dies. Okay. And the idea is that these ultrasonic waves can potentially be very precise. And so it can minimize the excessive damage that was seen in the procedure when it was done in the 1960s, 1970s. So this was a trial that was done in 2020, 40 patients, 27 got the treatment, 13 got some like sham fake ultrasound treatment. And so at the 12-month mark, you can see that there's a sustained benefit in the UPDRS score by 8 points. And this was just on one side of the body. So for one side of the body, having an 8-point difference is good, and it's similar to deep brain stimulation. Okay, so overall, this was a good sign, good chart. However, when we look at the side effects, there were 2 patients that developed essentially permanent weakness after the procedure. So that's 7%, which is a significant number. And if you were to remember, this was just one-sided. So if you were to do it on both sides, the risk will be higher. So that is something just to keep in mind here with this study. All right. But what do we know now, and what's next? So what we're hearing through the grapevine and people at Stanford who do this, and people around the country who are doing this, is that they think that they're getting better with the focus ultrasound. They can be more and more precise, so that they feel they're much more confident that they won't cause this weakness issue that was seen in this 2020 paper. So there are more trials going on. There's a trial that just finished, though the results are not out yet, about doing it on both sides. So, I think these are promising things people are saying. So my thoughts are, right now, I think this is useful for patients who can't get deep brain stimulation for one reason or another. For example, their age, or they have heart issues, because this is not like a procedure where you have to undergo anesthesia and it's like a surgery. It's more you wear a cap and there's energy that's shown at your brain. But at this time, DBS is likely superior based on the side effect profile. There's less side effect risk with deep brain stimulation at this time. However, over the next few years, we're going to see more data coming out from people who are getting more and more experience with ultrasound. And if they show that they are able to get rid of the side effects, then that would be great news. And it would be a competitor to deep brain stimulation. And then we have a question from Gil, any correlation with people with neuro issues? Oh yeah. So first, Gil's question, people with neuro issues in hippocampus areas of the brain. So hippocampus is a part of the brain that's important for memory, short-term memory, spatial navigation. And in Alzheimer's disease, it's one of the first things that gets impaired, hippocampus. But in Parkinson's disease, it does get affected, but it's usually much later in the disease course. Hippocampus is not felt to be a major area that's affected in Parkinson's disease, but it can be. Speaking again about the side effects of focused ultrasound, the biggest risk is unintended damage, that the ultrasonic waves hit something that they didn't mean to. And the problem is it's permanent. With deep brain stimulation, let's say you're slightly off, it's okay. You can shape your electrical field. You can even go back in and change the electrode positioning if you need to, but focused ultrasound, damage is done, damage is done. So that's the main risk. So, I think the groups really need to show that they have very high confidence that they're only affecting the area they want to. I think before this becomes really a mainstream procedure. Okay. Stem cells for Parkinson's disease. I don't really have any big updates from last year on this. Basically these trials are just going on. There's no major news here. But just for those who didn't listen last year or weren't here last year. So stem cells for Parkinson's disease. One important clarification is that these stem cells that are being used in patients right now are for symptoms only. It's not for a cure. It's not for slowing down Parkinson's. It's just it's for replacing dopamine. Okay. The idea is that dopamine cells are dying. Let's replace them. These studies were actually done in humans in 1980s, 1990s, and there were mixed effects. Some patients did benefit, and I read some articles that even 10, 20 years later, some patients had sustained benefit. Some had no effect, but the main reason it was stopped is that there were a subset of patients who developed uncontrolled dyskinesias. And the reason for that is that as Parkinson's disease progresses over time, your dopamine requirements can change. So let's say, someone puts these stem cells in your brain and it's giving you this amount of dopamine, but 10 years later, that may be too much dopamine. Your brain has changed and now you don't want that much dopamine, or if you get that much dopamine, it causes issues. And so that was one of the major reasons it was stopped. But they're doing it again, and the rationale is that they think they'll have more control over the amount of dopamine they'll be able to release from these stem cells. So trials started at Memorial Sloan Kettering in New York, and then there's trials all over the world. UK is one of the big leaders on this. They have a guy, Roger Barker, who I would say is the world leader on these stem cells. So he's leading that there. So I want to just note here that these patients have advanced Parkinson's disease, the ones that they're doing these in. And I think that they're doing that because they're probably waiting for that stage when dopamine requirement has stabilized. So they've reached, a certain advanced stage, and then dopamine requirements have potentially stabilized, and then they're going in and putting in these stem cells. So my thought is, I don't think this is something that most patients should be getting. It's, there's a high risk of dyskinesias. And there may be some select cases where this will be useful. But I just want to make you aware of stem cells because I know you're going to hear about this in the news. All right, so a summary, I talked about some disease-modifying agents. We're having 4 in phase 3 this year, which I think is good news, and let's be hopeful there. Symptomatic therapies, I talked about 2, and we need more information and data before these become mainstream. All right, now Q&A. And so let me just stop sharing my screen and feel free to ask any questions.
Thanks, Dr. Chattree. That was very interesting as always. Appreciate both the high level overview and also your thoughts. So I see questions coming in. So
yes.
away.
Are dopamine requirements related to movement or exercise? Yeah, to some extent they are. I think that it's a little bit complicated. I don't think it's always like one clear way, but when you exercise and move, your brain both needs more dopamine and your brain can produce more dopamine. So, your exact dopamine requirement may potentially depend on the type of exercise you're doing and the kind of level of dopamine your brain is able to produce. So these are 2 variables that do affect dopamine requirements, yes. Yeah, the glove with stimulation, I don't have updates there. I do know that last I heard the trial is on hold related to something with the glove, but I don't have more details there. Yeah. Yes, I'll send a copy of my slides to Robin and then she can send them. Yes, definitely.
And I'll just say that the slides and the recording will be posted online to our website in probably by Friday.
Great.
And Margaret Ferris talked to the group last month about focused ultrasound and PBS. And I think, isn't Stanford participating in a trial on focused ultrasound?
They are, yes. Yep. So I don't think we have the results there, but
No.
and I think that the recruitment has stopped, but yes, they are.
Okay, if anybody else has questions.
Advanced PD can be diagnosed through a clinical exam. So the physician can make that diagnosis based on the examination.
And maybe could you say what is advanced PD?
Yeah. Advanced PD is when walking really starts to be affected significantly, in the sense that falls are there's a high risk for falls, and there's something we call postural instability, meaning slight abnormalities in the ground surface or anything that can kind of throw off your body posture when standing or walking. It's hard for your body to make up for that. So like we sometimes do that test in the clinic where we pull you a little bit. So we're testing what's your body's ability to correct for the pull that I'm placing on you. So as that starts to get affected, then it starts becoming more advanced PD.
Dr. Chattree, can you open up the question and answer box? Are you able to do that?
Oh yeah, let me see.
Yeah. Mm-hmm.
I think I answered. Oh wait, let's see.
I think these are.
Okay, does the type of exercise make a difference to dopamine production? I think it does. I would say it does. Do I know whether high interval is better or worse? That I don't have an answer for you. I'm not sure. I do know that in the trial they did 30 minutes of continuous exercise stationary bike with the heart rate. They had a special formula, but it was like, probably around 100, slightly above 100. And yeah, thank you, Mary. Mary is mentioning that the glove study is continuing in Portland through the manufacturers of the glove, and she's provided contact information there. That's good. How would you isolate hand opening and closing? Yeah, Gil asks an excellent question. How would you isolate hand opening and closing being slowed bilaterally due to RA, so rheumatoid arthritis, osteoarthritis versus bradykinesia? It is challenging, for sure. I would say one of the main things we look for is decrement. So are you able to initially do the movements good, but then they start to slow down and you're not complaining of pain? They just are slowing down, even though you don't want them to slow down, and you can do them. But for some reason, around the 6th movement or 7th movement, they're starting to slow down. We call that decrement. That's more specific for Parkinson's versus arthritis. Okay. What does stress do to Parkinson's? I think that stress can make Parkinson's symptoms worse, and it can make the progression of the disease. It could also affect the progression of the disease. But I don't think anything definitive has been shown there, but I do feel like it could do that because, yeah, stress can have significantly negative effects on the brain in general. Yeah. Mark, at night, I don't take cinnamon and all my smelling seeds. Okay. Mark, I think, it's a good question. I think let me speak in a general way. I can't give specific medical recommendations to you because, I haven't seen you in clinic, but let me speak in a general way. Typically, as Parkinson's disease progresses and at night, steps become shorter and harder. Once the patient starts to feel that there's a safety issue or it's really becoming challenging to go to the bathroom, tell your doctor right away. And I do think that a medication that typically it's one medication that lasts all night long, it could be recommended. Yeah, but speak with your physician. Oh yeah, what is the ideal formula? Let me pull that up. Give me just a few minutes, and I have that in my notes. Okay, I'm gonna share my screen again, just to show you, and you guys can. Okay, do you see this?
Yes.
Okay. Yeah, so this is the study, and this is how they calculated the heart rate. As I said, it's a little bit complicated. So basically, first you calculate your HR max, 206.9 minus 0.67 times your age. Then you plug in HR max into the second formula. So you have to know your own HR resting. So you have to calculate that your resting heart rate. And then you plug in HR max based on the first formula. And what you get then is your ideal moderate intensity heart rate. Okay, 30 minutes, 3 times a week, stationary bike. And at the 6-month mark, those that were doing this consistently overall did better in their movement ability.
And consistently was 30 minutes, 3 times
a week, every week. Yep, for 6 months.
Yeah. Which is less than the usual suggestions we hear. Yeah, far less, in fact. Yeah, half as much, I would say, at least Yeah, interesting.
Yeah.
Will you share this? Will you add this slide to
Sure,
your
I'll add it to the
slide?
slide. Yes, yes.
Great, that'd be wonderful. There was one more question in the chat I saw
Okay.
about Cinemet dosing.
6-7 pills, medium. That's medium, even like a low medium. Yeah. But yeah,
So,
there is no true maximum dose on Cinemet. It all depends on your bodies. We're just replacing something that your body was making normally. So there's no true maximum. It sort of depends on patient to patient.
okay, maybe you could, I think on the levodopa page, let's see on the symptomatic therapies,
Yeah,
you talked
yeah,
about the subcutaneous
yeah,
levodopa patch.
yeah.
Were there other formulations of levodopa on that page? Are researchers working on different formulations besides a patch? I know we have the inhaled version
Sure.
now.
Yeah,
We have
I think I had the inhaled version there.
the
There
film.
is the intestinal gel. That's for very special cases, but that's where the levodopa comes in through a tube into the stomach, or the intestines. No, honestly, I don't know. I think that what I've been reading about lately is the patch. I'm sure there may be people working on other formulations, but that's the latest one that I know about.
Okay. All right. Are there any more questions? Oh, here we have another Q&A question.
Each morning, 30 minutes, heart rate 115. No, I think that's good, Mark. Yeah. Good solution to constipation with PD. Okay, so again, speaking generally, yeah, constipation in PD, as we know, is a major issue. I would say there's a hierarchy in terms of, or not a hierarchy, there's a progression of what things to do. So first is dietary interventions and lifestyle modifications, meaning fruits, vegetables, whole grains, prunes, prune juice, lots of water, and walking, movement. Movement also helps with bowel movements. Okay. Then let's say that's not effective. I like adding Senna and or Miralax, some combination of those two. Miralax, you can titrate it. There's a cap, you can fill it to how much you want to fill it. You can experiment with that. And then Senna can be once or twice a day. Both of those are over the counter. And so start with that. Then there's other prescription medications. And lastly, I will say there was a trial. I'm pretty sure it was phase 3. So I think this will be submitted to the FDA for a medication designed specifically for constipation and PD. And the trial, I think it had very strong results. It was done last year. I didn't include that here, but yeah, so we may see in tough cases a medication that's just for PD in the next 1 to 2 years. Yeah. From Q&A, does DBS eliminate bad cytological? So in the sense that if you get a certain type of deep brain stimulation, which is the subthalamic nucleus deep brain stimulation, oftentimes you can cut your medication down by 50%. Every patient's different, but that's the goal. Okay, that's an ideal scenario, that you can bring it down by 50%. In that way, if you have 50% less medication, you potentially have less side effects. So it is possible that in a roundabout way, DBS can help eliminate some of these side effects. The last comment I would say is if you are having impulse control issues, if you haven't already, I'm sure you have, speak to your physician right away. You can make adjustments to the medications to try and deal with that. Because yeah, 40% of patients eventually develop some sort of impulse control issue on dopamine agonists. Okay, so my practice, and again, every physician is different, but we try to, once people start reporting that it's time, if you're on a dopamine agonist, it's time to transition off. Botox, bladder controls when other drugs have not worked. I've seen good effect in a few patients. So it's worth looking into. So you could talk to your doctor about getting a referral to urology. But I've seen some patients get good effect. Yeah.
Are there any more questions for Dr. Chattree? Well, maybe we're questioned out then.
Well, thanks again, everyone, for coming, participating. Really excellent questions, and I'll send Robin my slides, and she'll get them to you.
Sounds good. Thanks, Dr. Chattree. Appreciate your good talk as always and answering all the questions, and enjoyed the nice weather out there. Bye-bye. And everyone, I'll see you next month. Let's see what's next month. Next month is March, and we have another physician speaker from Stanford. Oh, yes. And she will similarly be speaking on Parkinson's treatments, but not things in the pipeline. She'll be talking about things that are already available and how to get the best care for your best treatment for your Parkinson's disease or your family member's Parkinson's disease. So that's next month. So we look forward to seeing everyone. And again, we'll reschedule today's speaker, Dr. Maya Katz, for probably May or June. We have speakers now for March and April. So we're good for a couple months. All right. Bye, everyone. Have a nice afternoon. Bye-bye.